Welcome everybody. My name is Ádám, a third-year resident doctor in the obstetrics and gynecology clinic, and I would like to present my 9 months progress. Here you can see the list of my team members and my vision 2, which is endometriosis-related pain should be a concept of the past with 1 pill a day. And I have my own mission 2, which is to find the most effective pain relief therapy for endometriosis. We have 2 ongoing projects. The first one is already submitted, and as you can see, I started the second one earlier than the first one, but the second project is a little bit bigger and needs more time to processing the data. So my first topic is comparison of robot-assisted versus conventional laparoscopy for treatment of endometriosis. It's a systematic review and meta-analysis. Why this topic is so important? Because endometriosis carries a high individual and society cost, and there's a high pressure and a growing need to treat with the most appropriate and the highest quality care. We have a lot of several therapeutic options, for example, medical therapies, surgical interventions, and other non-medical strategies. But let's focus on the surgical interventions. We can choose between 2 approach. The first one is the conventional laparoscopy, CL. This is the gold standard therapy nowadays. And there's another newer option. This is the robot-assisted laparoscopy, which is REL. We have a third option, laparotomy, but it's nowadays just a rescue option if you have a severe complication in the before mentioned 2 techniques. But what offers to us this new technique? Here you can see a list: reduce pain, less blood loss, reduce risk of infections, faster recovery, more rapid return to the normal life. But my question is, can we observe these advantages in the everyday practice? And that's why our aim is to compare the REL and the CL for the endometriosis surgery regarding the perioperative outcomes. Our question, is REL safer and more effective than the CL in the field of endometriosis surgery? Our population is patients who underwent surgery for endometriosis. Our intervention is REL, our control is the CL, and we will examine the perioperative outcomes. Of course, our hypothesis is REL is superior to the CL in the field of endometriosis surgery. And at the end of the whole process, we can turn this knowledge back to the bedside and improve the surgical treatment of endometriosis. We conducted a systematic search in 3 online databases. Here you can see my search numbers and a very simple search key. At the end of the whole selection process, we got 13 eligible full text. Here you can see the list of our outcomes: intraoperative complications, postoperative complications, operating room time, operative time, estimated blood loss, number of conversions, number of rehospitalizations, and length of stay in hospital. Surprisingly, we got the result that we can't observe any significant difference between the 2 techniques. And I bring you the most important figure. What we can see here, we compare the REL and the CL regarding the operative time, which is measured from skin incision to the wound closure in minutes. And what we see here, approximately 30 minutes longer, we can observe 30 minutes longer operative time in case of REL, which is not what we expected. Here's the baseline characteristic table. I would like to highlight here that the most of the studies are retrospective and we have only 1 RCT. And what's more, there's a high heterogeneity regarding the severity of endometriosis. What was our conclusion? For endometriosis surgery, REL does not have statistically demonstrable advantages over CL in terms of perioperative outcomes. So what's our suggestion, the implication for practice? CL should be the first choice, but in the practice, it's more complicated. It's not so easy in 1 sentence answer. Implication for research, need more randomized studies, need to investigate the practical advantages over CL, and need to investigate the medical economic impact. We already submitted to the British Journal this article 8 weeks ago, but didn't get any answer yet. So far we talked about the surgical interventions. Now let's turn to the medical treatments. My second topic is investigating the most effective medical treatments for endometriosis-related pain. It's a systematic review and a network meta-analysis of randomized controlled studies. Almost every 10th woman suffering from endometriosis, the symptoms can be very diverse: dysmenorrhea, pelvic pain, dyspareunia, and so on. There's a lot of therapeutic options, but let's focus on the medical ones. We can divide it to two groups, hormonal ones and non-hormonal ones. And we choose the follow-up time based on the limitations because of the side effects of the hormonal treatment. So that was 6 months. Here you can see the investigated therapeutic options. The size of the green bubble represents the estimated effects of the drug types: combined oral contraceptives, gonadotropin-releasing hormone antagonists and agonists, progestins, aromatase inhibitors, selective estrogen receptor modulators, non-steroidal anti-inflammatory drugs, and opioids. Our question was, which is the most effective therapeutic option for endometriosis-related pain? Our population, women of fertile ages with endometriosis. We compared the before-mentioned medical therapies, and our outcome is the endometriosis-associated pelvic pain in different pain scales. Our hypothesis: oral combined contraceptives are superior to the other therapies for endometriosis-related pain. And after the end of the whole process, we can increase the effectiveness of pain relief for endometriosis. We conducted a systematic search in 3 online databases. Here you can see my search numbers and the 4 main boxes of our search key. At the end of the selection process, we got 47 legible full text. And in this week, we got the final results. But we use very difficult analysis. That's why we need some more time to interpreting our data. We finished the methods, and we will finish this project on the next month, July, and our target journal is reproductive biology and endocrinology. That was me for today, and thank you for your question. I bring you my favorite Latin phrase: something for something, quid pro quo. Thank you.
A very nice presentation and nice progress. I have 2 questions. Could you tell me the incidence rate of endometriosis here in Hungary? And the second one is, what could be the difference after radical robot-assisted surgery and laparoscopic surgeries regarding the pain relief? So why is either less or why is more after other surgeries?
Thank you. So your first question was the incidence in Hungary. And it was, I mentioned, every 10th woman suffering is almost the same in Hungary. It's based on the general healthcare of the certain country with what you would like to ask. So if you ask for an Asian or an African country, you will get different numbers, but it's because the diagnosis of this disease is very hard, very difficult, based on maybe just the symptoms or just different imaging techniques. So that's why there's a very high heterogeneity if you see in the worldwide, but it's in Hungary we can say that number is 10 to 15%. And the second question is, can you repeat that?
Regarding the pain relief, what can be the difference after robot-assisted surgeries and laparoscopic surgeries? What do you think?
Yeah,
or is there any difference between?
I didn't highlight that. There's also high heterogeneity regarding the type of interventions, because in some article just investigating the a certain type of interventions. For example, just cystic endometriotic nodules. We excise these nodules, just the bladder ones. And other articles investigate all the type of interventions what we can do regarding endometriosis. So I can't tell you the exact answer because there's a lot of type of interventions, not just radical ones. Because if somebody would like to be pregnant, we would like to less organs, or we don't want to excise all the parts which is contained with endometriosis. So these radical types of interventions is not so common as you think.
Okay, thank you very much.
First of all, congratulations. I mean, you already achieved, submission one paper. I'm innocent of the topic, you see, but I see that you state, or you found that actually there are 30-minute difference between the two types of surgeries. At the same time, if you look at the individual measurements, actually the difference is, 77 minutes versus 210 or so. So what, or 221 or even more. So what is the reason for that? Because this is maybe more important than or co-founding factors. So
that's what I mentioned before. I didn't highlight for you that, for example, in the 75 minutes Carpentier, they only managed cyst bladder endometriosis. So it's just a certain type of interventions, all the included interventions, just these type of interventions. And for example, other ones, they, in case of 200 minutes, it's bowel resection and a lot of cyst or etc., maybe hysterectomy. So that's this heterogeneity cause these differences.
I would just have one question regarding this as well, that were there complicated operations done by robotic surgery as well as laparoscopy, and they were compared together? Or isn't it possible that the radical operations were mostly done by robots? On the contrary, the more simple ones were done by laparoscopy? Or
we included only
check this
papers that in one institute. So every operation was
so in each institute the same type of operations were done as well, by robot and laparoscopy as well.
And I mentioned that it's just retrospective studies and not randomized control studies. So how they decide to which patient goes to laparoscopy, which is robot, is based on, in the most case, the surgeon. Okay. And it's one of the reason why we get these differences, because the surgeons say that it's a little bit harder case, so use the robot. As I mentioned, this list of the bunch of advantages. So that's why we choose the robot. And the harder, the several cases they bring.
Can the two groups be compared? The robot group in terms of difficulty, the operations, and the groups of the laparoscopy group? Just because this could cause a bias, if not. Was it checked if it's if the difficulty of the two?
Difficulty is measured by the RFS score.
But was it the same in case of the robotic surgery and in case of the laparoscopy
almost
surgery?
The same.
Okay, thank you.
So my only question is that these limitations, you still stick to your final conclusion that there is no difference, or can we even conclude or make any conclusions after comparison of these publications? Because there are so many limitations, so heterogeneous group of patients.
My fine. If I would like to answer it with one sentence, it's just a snapshot. Maybe after 10 years or 20 years, we will get absolutely different results, because the surgeon who made these interventions, they spend the most time of their life with the CL techniques, the conventional techniques. And if they spend more time with the robot-assisted techniques, these advantages will come out. I think that if I will be asked.
Thank you, Adam. Just 2 comments for the audience, mostly for those who are not coming from gynecology. So the prevalence of endometriosis is around 20% at least. So it's really a huge burden we have to cope with. And the second, what also István asked, whether we should use the robot-assisted techniques. Nearly all the countries in Europe came to the decision that there is no reason for using the robot-assisted technique because it's so expensive in the cases of endometriosis. Of course, in the USA, they use the robots for each and every operation, but in Europe, it will be restricted to the most complicated ones.